Good afternoon, ladies and gentlemen. My name is Joseph. It is my pleasure to welcome you to this virtual press conference. We are gathered here today to discuss a very important study that will have significant impact on the diagnosis of coronary artery disease in India. So we have with us the authors of this study and also a very eminent panel of experts from the field of genetic diagnostics and cardiovascular disease to shed light on the latest findings and its implications for cardiovascular health. So before I get started, I want to inform the journalists in the group that we have a Q&A session at the end after the spokespersons have given their talk. And please do raise your hands in the Zoom interface and I will unmute you. Right now I have muted everyone and I will unmute you at the end when you raise your hand. Or alternatively, you can type in your questions in the chat window and we will address it to the panel. In the interest of time, I also request the speakers to adhere to the time allocated for them to on their talk. And without any further delay, I now hand over to Dr. V.L. Ramprasad, CEO of MedGenome Labs, to introduce our speakers and take this press conference forward. Over to you, Dr. Ram. I'll stop sharing.
Thanks, Joseph. Just give me a second. Hope you can see the slides I just projected for having clarity. And good afternoon, everyone. Good afternoon, friends from the media. And good afternoon to all the senior cardiologists who have taken some time off to be here. Really glad that you're all here. And also good morning, very good, early good morning for Dr. Sheikh Kadresan, who's joining us from Boston. Just wanted to set a couple of minutes of context here before we go into the next agenda of the meeting. We are very glad MedGenome is very happy, along with its collaborators, clinical collaborators, that we have just published a peer-reviewed manuscript on the highlighting what some of the key results of our genetic study, which we called as genome-wide polygenic risk score. Done on a set of about approximately 3,000 individuals across the country from different large tertiary cardiac centers. And this is genome-wide polygenic risk score heralds a new era of genetic screening. It's in nascent stages, but it is very promising. It basically stratifies an individual at any point of time. It could be when an individual is born or when an individual is around 30 years of age or 60 years of age, to calculate or to screen an individual and stratify him whether he is at a high risk of getting a coronary artery disease, or it could be a diabetes, but this study is only purely on coronary artery disease, but it can be done on several other complex diseases for which there is an underlying genetic basis. So this is something remarkable for two reasons. Number one is, of course, this is the first study in South Asia. And the second reason is the impact it's going to have on the population in the next few years to come. So far, you've been heard, or many, including many of the clinicians, have heard about the inherited diseases where genes are only the genes only play the role of causing a disease. But in more common diseases or complex diseases like coronary artery disease, which you also call it as coronary heart disease, ischemic heart disease, heart attack, myocardial infarction, there's several other names for it. And also other common diseases like diabetes, hypertension, stroke, inflammatory bowel disease, schizophrenia. These all diseases, not only genes play a role, but lifestyle and various other environmental factors play a critical role. So far, it has not been easy to tease out or quantify the amount of bad genes or the amount of genetic risk an individual has and inform them or pre-inform them preemptively so that necessary management or lifestyle change or dietary changes or medications, whatever management can be done, was able to done so far. So this polygenic risk scores last several years, maybe about 5 to 6 years, worldwide people have been doing on the research level. Pretty impressive work has been done, and we have today one of the pioneers in that, a cardiologist and a geneticist, Dr. Sheikh Kathresen. I will go through the introductions in a while, who can give you much better insight as to what is happening globally and how it can help reduce the burden of coronary artery disease. Just wanted to introduce few other speakers. We have most of our collaborators. I'm really happy about it. We have Medgenome has collaborated with about 6 centers for this study across the country, starting from Madras Medical Mission from Chennai, and of course Broad Harvard Institute, that is Dr. Sheikh Kathresen, who initially helped us and took us hand holding through the work, since they were much early, and they've really set this whole of polygenic risk score globally. And also we have a collaborator, Dr. Rajiv Gupta from Eternal Heart Center from Jaipur. He has been pretty supportive for us from the initial start of the study. He pretty much realizes the importance of genes and genetic scores in coronary artery disease, and we really thank him for the support. And we have, of course, one of the premier cardiac centers in the country, Narayana Institute of Cardiac Sciences. We have several senior cardiologists who includes Dr. Ramesh Sheshadri, Dr. Julius Punnen, and Dr. Varun Shetty, Dr. Bhagirath Raghuraman, Dr. Pradeep Narayan, and Dr. Rajendra, and of course, Dr. Muralidhar Kanchi, who was pretty much actively involved in this study. Without these collaborators, we would not have done or possible to complete the study, because to identify the genetic risk factors, understanding the clinical part of it, understanding the clinical profile of the individuals is extremely important. And I think this is a very, very happy occasion for us, because it's a multi-centric collaboration, went on pretty smoothly. In 2016, when I and my chairman met Dr. Sheikh Kathresen in Boston, we had a quick chat on the polygenic risk scores, and that's when we started off talking to various clinical collaborators in the country. And I really thank all the clinical collaborators, hospitals, including some of them who are not here, Amrita Medical Institute from Kochi, and also KMCH from Coimbatore, who are also part of this study. So it's a PANS multi-centric collaboration. We got recruited or collected samples from several of the individuals who had coronary artery disease and who didn't have it from various centers. And we did the last study. I can go into the specifics once you ask the Q&A. I just wanted to keep as brief as possible. So all through this discussion, starting from, I would like to start with Dr. Ajit Mulaseri, who is the Director of Cardiology at Madras Medical Mission, Chennai, who will highlight India-specific incidence of coronary artery disease, the burden it has on population health, and what are the things that every cardiologist in the country is looking at a population level, and what are the risk factors, including the genetic factors, briefly for about 10 minutes. And also he'll highlight the study we did. Then we move on to Dr. Sheikh Kathresen, who will give the latest perspective as to what is happening globally, global status, and how these can be implemented at the clinical level for the patients or for a population to really reduce the burden of CAD and also similar diseases. And also, I think it is very important for us to understand the views of some of the senior cardiologists who are in our amidst here, to understand their perspective and what are the things that we need to do moving forward, so that we also can keep this in our roadmap before implementing this anywhere in the clinic. So I wanted Dr. Ajit to take this up and just give his perspective on a couple of points which I mentioned in the agenda for about 10 minutes. Thank you.
Dr. Ajit, if you can unmute yourself, I've given you the permission.
Is that okay?
Yes, we can hear you now.
Okay. Sorry. So the agenda for today is to talk about the incidence of coronary artery disease in India. From the Journal of Genetics, we know that the incidence of coronary artery disease in India is approximately about 10.5%. And this has increased both in the urban and rural India. And this is a matter of concern because this exponential growth of coronary artery disease in India is seen in the last few decades. Now, traditionally, coronary artery disease is basically looked as an environmental issue. Basically, traditional risk factors like diabetes, hypertension, hyperlipidemia, smoking, these have been considered as traditional risk factors. And if you look at the Interheart study, which is a big study from multiple parts of the world, we almost suggested that 90% of coronary artery disease is environmental, and there's very little to do with genetics. And the reason was, unfortunately, that we did not know the genetics of coronary artery disease very, very accurately. Single gene disorders for coronary artery disease are there. Traditional, like the familial hyperlipidemia, it is 1 in 200, and that's very small. Most of coronary artery disease is polygenic, and polygenic means multiple genes in multiple amounts. Now, the problem in India is that, number one, we see people with coronary artery disease presenting younger. We had a paper presented in JAMA of MI patients, and we found that 22% of the patients who had myocardial infarction or heart attack happen to be less than 45 years of age. And this is very, very common in India that you will see young people. The mean age of presentation of all MI is at least a decade earlier. We see more diffuse disease. We see more difficult disease to handle. And we used to traditionally say that, oh, you know, it could be because of higher diabetes, poor lifestyle, sedentary lifestyle, many of the issues which we think were, environmental. But the fact remains that Indians as such are smaller size, smaller stature, wherever they may be. Maybe they're in India, they may be in the UK or the US, they may have, they carry with them the genetics and their poor outcomes wherever they go. So the fact is very clear that people of South Asian origin and Indian origin have coronary artery disease, which happens younger. They carry their genetics with them wherever they go. And we feel that the people with young myocardial infarction and young heart attacks, which is a big problem because it's death at a younger age, economic burden for the country and the family, are much, much higher. And we traditionally had no clue as to what to do. Now, the polygenic risk score is the first time, and this paper addresses that, for two reasons. One, it sees the score as pretty the same, whether you say it for UK-based Indians, Bangladesh people, or the current study of Indians. The risk score is almost the same. That means that wherever you go, the South Asians carry the same risks. That is number one. Number two, for the first time, we have used the GWAS scoring to basically put the European genes together in an Indian population, putting together the ancestry of people from South Asia and create a score which becomes very, very important. Why is it so important? Is because you can do it in one study. You don't need repeated studies like sugar, cholesterol. Your genetics is once and for all. And number two, predict a score. And the score is in the higher range or the higher tertile, then people will have a higher incidence of coronary artery disease. Let me tell you an example, what happens in a clinic. You have a young guy coming for a master health checkup. He says that, well, he says that he has a family history of heart disease. His father or uncle or somebody died. You look at him, he's a lean, thin guy, pretty fit. You look at his sugar, cholesterol, he's not a smoker, he's not a diabetic, he's nothing. You do a risk clinical evaluation, maybe a non-invasive test, maybe a CT scan because he's of high risk. You find nothing. You send him home because his lipids are not very high. You put him on a very small dose of statin, send him home, and 6 months later, he gets a heart attack. And he comes to you. And then you wonder what happened. You did all the tests, you did all the risks, and you didn't find a problem. And you just left him alone. And then you say, oh, it's stress or something like that. But these people who are at high risk, if they can be identified early with these sort of scores, then we could do aggressive lifestyle, aggressive medications, aggressive looking after weight and sugar, and prevent coronary artery disease to some extent or postpone it for some extent. So this is the aim of the score. The score, for the first time, which is published with many of my colleagues and Shaker's group, clearly with the medgenome has helped us to now find something which has been a bit abstract, which is the risk of polygenic traits, to put it into a number so that we can identify people and put the risk to them and treat them aggressively with lifestyle. So this is what I have to say about this study. The study is published in a very accomplished journal, the Journal of the American College of Cardiology, which is in the top 2 or 3 journals of cardiology. So it has tremendous significance and is for the first time from South Asia. Thank you very much.
Yeah, so thanks, Dr. Ajit, for those details you have given. Maybe at the end of the session, there could be some of the questions related to these. I think I will now go on to Dr. Katresan, who is currently the Chief Executive Officer of Verve Therapeutics, which is doing some of the groundbreaking work in genetic therapies or gene-based therapies for some of the cardiac diseases. And he is also the professor of medicine at Harvard Medical School on leave, and at cardiology division, Mass General Hospital. And he's one of the pioneers who have developed and implemented and also published several key papers, some of the papers that are published in Science or Nature Genetics, etc., on polygenic risk scores in coronary artery disease. Not only polygenic risk scores, he worked on a lot of genetics of coronary artery disease. I think I'll leave it to Dr. Shaker Katresan, who can spell out some of his experiences and what kind of impact this will have. Thank you. Okay. So maybe before Dr. Katresan comes back, I will give you a few more details on this study, what we have done, especially for the media people to really understand what this is. So as Dr. Ajit has briefly mentioned that diseases like coronary artery disease is polygenic in nature, which means that not one single gene or single variant influences the disease outcome, but there are millions of genetic changes that could be there in an individual, which will influence whether an individual gets coronary artery disease at a very early age, how severe it is, and somebody is not getting because of some of the protective variants they have it. So what we have done is in this study, we have worked with, as mentioned, some of the eminent centers in the country, some of the cardiologists here. We have recruited about 3,000 and odd individuals. Half of them did not have the disease and half of them had coronary artery disease. And these have been well documented and well clinically identified as per the international criteria. And we have done what we call as genotyping, or basically identifying the genetic profile of each individual across the genome. So our human genome is pretty large, and we have done a method to identify these genetic variants across the genome. And once we have done, basically we compared the genetic profiles of those individuals who have coronary artery disease compared with who don't have the coronary artery disease. And then we picked up those variants and we ran some statistical algorithms and also statistical models, which I don't want to go into details here. If anybody is interested, can go through the paper. And basically what these bioinformatics or statistical algorithms give you is, at the end of it, they give you a score for each individual, and this score defines the risk that individual has it. So based on the population's range of this risk, we give a cutoff as to what is the normative cutoff currently, and whoever comes above this cutoff, we identify them as a moderate risk or a high risk individuals. Now, what is very interesting is that when we did this study, we found a significant odds ratio or odds of getting a disease in those individuals who were having myocardial infarction or coronary artery disease at a very young age, at the age of 45 or less than 45. So, and also considering some of the statistical attributes here, the positive predictive value, which means when I say somebody has a high risk, the chance that individual might get a coronary artery disease is called positive predictive value. So the positive predictive value in this study design was almost up to 90% in the young onset cases, so which is very significant. So if I tell an individual it's a 90% positive predictive value with a sample size, and there is quite a bit of certainty that the risk we are attributing is pretty accurate. But having said that, just wanted to inform you all that these polygenic risk scores are not like any diagnostic test where it is 100% foolproof. It is a screening solution currently. We are pretty sure these will refine as we go on, as technology evolves, as the science evolves. But currently these are screening solutions to quickly identify individuals and stratify them whether they are high risk or low risk. So I could see Dr. Kadrishan back on the call. So Joseph, can you connect? Yeah, so we'll come back. I think there are some connection issues here. Maybe I will take this further to Dr. Rajiv. Dr. Rajiv Gupta is Chairman Medical Sciences and Preventive Cardiology at Eternal Heart Center. He has been actively involved in this study and has been closely working with several other groups also, including Inter Heart Study and other places. So Dr. Rajiv, could you throw us some light on the polygenic risk scores? How do you think it would be useful in regular clinical practice, and what do you think are things that patients or clinicians have to do?
Thank you very much for this opportunity. Actually, we have been seeing young people with heart attacks, and India or South Asia as a whole, I think contributes almost half of the young people with heart attacks in the world. So clearly there is a major problem in our country. We all know the risk factors like smoking, like high cholesterol, like diabetes and other risk factors. But what we have been thinking all through is that there should be some gene risk factors which we can identify at a very early age. So the biggest gain out of this gene risk factor is that now we can diagnose a person who is at risk at the age of 15 years or 20 years or 25 years, and then advise him treatment. Now the relative risk odds ratio which we found in our study of gene risk score predicting heart disease is about 1.5. Now putting that into context, the risk from smoking is about 1.7. The risk from high blood pressure is about 1.3, and the risk from diabetes is about 1.4. So I think clearly the gene risk score is much better as compared to the traditional risk factors. The other advantage of this particular gene risk score is that you could do the risk scoring at an early age, because most of these risk factors like hypertension, diabetes, high cholesterol, they come after the age of 40 years. So if you want to diagnose disease in an early age, and if you want to advise a person what is his risk for developing heart disease, he should get the test done early at an early age. If there is a family history of there is some suspicion of heart attacks, and then we can tell the patient that you need to lead a very aggressive lifestyle. You need to live a very good life, like you need to exercise regularly, you need to not smoke, you need to watch your weight, watch your waist, just watch your blood sugar levels. So I think it's basically a healthy lifestyle which has to be in focus. Now, there have been studies which have shown that if these people with high gene risk score are given drugs like statins, or they reduce their cholesterol to a very severe degree, it is useful. So in person who has a high risk score, especially in a young person, the first thing we advise him is healthy lifestyle. And if he doesn't want to, well, he doesn't stick to it, or he continues to have a risk in terms of weight or cholesterol levels, then we can put him on a dose of statin to maintain his cholesterol levels. So I think that's where the importance of this particular score lies. As clinicians, I think we are deeply interested to do this particular test in our patients. We are also looking forward to more research, because not only the first heart attacks, but the second heart attacks or the third heart attacks, which is known as secondary prevention, also is a very important problem. Now, if a person has a heart attack, he wants to be sure that even if he controls his cholesterol or whatever it is, he is at a low risk, then we can use this gene risk score to identify the risk status. And again, we can give him a very aggressive sort of a management. So I think it directly helps the management of the patient. It directly helps the management of a person if he is not symptomatic. If there are any questions, I'll be happy to answer them. Thank you.
I think we'll try Dr. Kadiresan one more time to see if he's able to connect with us. Dr. Kadiresan, please do go ahead and try one more time.
Yeah, so it's a pity that we couldn't reach out to Dr. Sheikh. So I'll move on to the next, some of the key stakeholders who are some of the eminent cardiologists who are contributing to the reducing the disease burden by their regular clinical practice and who've been working with us as a part of this collaboration. Can I request Dr. Julius Pnen, Dr. Ramesh Sheshadri to give their thoughts on how the risk stratification would help them identify individuals at risk in the clinic and how better management can be done in these individuals.
Dr. Julius, I've unmuted you. You can go ahead first.
Good afternoon, everyone. Can you hear me?
Yep.
Yes, sir.
So this is a very important study, and it has rightfully been published in one of the best journals, and it has also invited an editorial in the same issue of the journal. So that shows the importance of the study as such. So this has highlighted the ancestry-specific polygenic risk score, which is specific for South Asian population. We know that some of the diseases that affect the cardiovascular system are monogenic, like the familial hypercholesterolemia, as Dr. Ajit was mentioning. And certainly coronary artery disease or ischemic heart disease is of the polygenic variety. And there is also a very strong environmental contribution to this. So maybe sometime in future, there may be studies which combine the genetic and environmental modifiers to this. And as the study has told us, this is something which we can look at in predicting the risk for the population as a whole. Maybe you can do a whole genomic sequencing at the time of birth and have a fair idea about who is at higher risk if they fall in the higher category of risk. And we can direct specific counseling in terms of exercise, lifestyle modification, diet, etc. And also look at probably using medications like statins or PCSK9 inhibitors like alicocimab or everolimus. So there are lots of interventions you could do in terms of prevention. Prevention is an area which we haven't given as much thought as before. And in order to do prevention, it is very important to understand the population who is actually at risk. And if you can zero down the genetic factors like this study has done, it would really help us in identifying the subset of people who are at higher risk and targeting preventive therapy to them at a very early age. Thereby, the whole population-based risk can be brought down. And I congratulate the authors for such a beautifully designed and thought out study, and also for being able to do whole gene sequencing for good part of the study subjects. Thank you.
Dr. Ramesh, you can go ahead, sir.
Can you hear me?
Yes, sir, we can hear you. Please go ahead.
Yeah. Congratulations on a fantastic study. Even if it is half as predictable as you claim it to be, I think it's revolutionary. My question is, how practical is it to adapt the study into our regular OPD, on a day-to-day basis? What are the limitations of this study on our regular practice lines? And two, how much is is there a quantitative assessment as well that can be done as to who is at high risk, who's at a moderate risk, and who's at low risk? And the third question is, this is a prospective study you've done. Have you done a retrospective study as well, looking at all the patients who's had CABGs or who's had angioplasties, and done a study on them to see that in how many of those patients correlate, and does it stand at 90% of what you claim to be? Congratulations on a fantastic study.
Yeah, Dr. Ramesh, I don't know, I can answer this, maybe it's a little preemptive, but I can repeat it again at the end of the Q&A. So there are 2 points here. Implementation in the clinic as far as the screening test is concerned is not a difficult thing. It takes about a turnaround time of about 4 to 5 days. It costs about 5,000 rupees once in a lifetime. And once you identify an individual as a, so what we do is basically we give a score. It's a quantitative score. And this score has a cutoff. So what we do is we put the value of the polygenic risk score value for each individual into different buckets. So basically we divide them into what we call deciles or quintiles. And who come in the highest percentile on the extreme risk side. We are little conservative currently because we don't know how they work. So we are taking only the extreme risk bucket. That means the last decile that will be around anywhere about 5 to 10 percentile of the individuals who we call them as a high risk individuals. And 7th and 8th decile, or 8th and 9th decile, we can call them as moderate. At this point, we don't want to call anyone as a low risk, because the way individuals take, especially the patients or the individuals take, even though clinicians can understand, the moment you say low risk, it's going to be a little bit on the, there are other risk factors like smoking, hypertension, diabetes, which can still cause coronary artery disease irrespective of what kind of genetic factors you have. So currently we classify them into moderate and high risk. In fact, we have done some kind of a pilot studies on some individuals. So that's a part. Feasibility is not an issue. I don't think cost is also very high. I know it, for an regular ordinary man, 5,000 rupees sometimes can be difficult, but considering any kind of preventive tests that are done today, costs about 3,000 to 4,000 or 5,000 rupees. So this is once in lifetime, you understand. And please note, once it's the same cost you do for coronary artery disease, and tomorrow in under 2-3 months, we are starting work on diabetes. So it's going to be diabetes, hypertension, all put together. It's just can be one test, one screening test. Again, wanted to stress on that point, and give them a risk profile and stratify the individuals.
No, excellent. Excellent.
Second point to your question on prospective listing. This is basically a case control study design where we have taken individuals who had coronary artery disease already, either they have undergone CABG or bypass or a stent or whatever it is, or when they have underwent the scan or radiology, they had a severe ischemia or some kind of a plaque present there, and they have taken. But most of the patients had some kind of event happen. So these are the cases, and controls are age match, gender match, match for diabetes, hypertension, everything, and who did not have any kind of coronary artery disease evidence, not only event, but even on radiologically. And we have basically typed all of them. So that's exactly what I told initially. Again, to reiterate, if you have taken individuals who are young, who got heart attack or MI at young, that is less than 45 years of age, we have seen that the odds ratio is going on the polygenic risk score is going to 3.5 to 3.7. So which is significant. I can alert an individual very clearly. If an odds ratio goes above 2 itself, you have double the risk of an average individual. And the positive predictive value is about 90%. And again, the positive predictive values change depending upon the cases and controls you use. So this is turning out to be a really good one for us. And there is ample evidence, not only in this study, but you would have seen the lot of studies already published. Prospective studies to really see whether interventions will really help to reduce or mitigate the burden significantly or not are, I think, currently are being happening in US and Europe. I thought Sheikh was, if there, he would have given some really good insights on that because he's part of several studies there. Unfortunately, we couldn't get him. So that's the status currently, Dr. Ramesh.
The administration, the government must also be interested in this because it's a hugely preventive, mechanism. So is any of the government organizations involved in this? Is the ICMR not interested in this? Because it's something that's going to prevent the expenditure of the exchequer in years to come.
Yeah, correct. You're absolutely right. We haven't taken it across to them, considering, we just published it.
The reason I say this, the cost could be a little, effective then.
Yeah, you're right.
Thank you so much.
Thank you, Dr. Ramesh. I will take this, further with some keywords from Dr. Bhagirath and Dr. Varun Shetty. If they are there on the call, I would request you to give few words on this aspect. It will be useful for everyone.
We have Dr. Bhagirath. I'll just unmute him, and we also have Dr. Pradeep Narayanan.
Sure.
But unfortunately, Dr. Varun Shetty couldn't join us. So I'll unmute Dr. Bhagirath first.
Yeah, thanks.
Am I audible?
Yes, Dr. Bhagirath, please go ahead.
Yeah. Good afternoon, everybody. Again, compliments and congratulations on a fantastic study. The points that I wish to make here are that coronary artery disease in the South Asians is almost in epidemic proportions. We have many young individuals in the peak of their lives and careers who face severe coronary artery disease. And because of this, the career is crippled, their entire earnings is crippled, and there's an entire family dependent on them for their livelihood. So this again redefines the importance of such a study. Now, I would say that this study is really important because it gives you a fresh perspective into identifying individuals at high risk. As a clinician, we go through the usual tests that are to identify usual risk factors. So basically, it's the ECG, the echocardiogram, the treadmill, the lipid profiles, the blood sugars, and so on. So as Dr. Ajit rightly pointed out, most of these, if they are almost within the range, we would advise such individuals lifestyle modification and ask them to come for follow-up in 6 months or 1 year down the line. However, this study is able to give you a fresh perspective, and even if all these values are totally normal, yet you can identify who is an individual at high risk, or particularly pick up those who had a family history of coronary artery disease or a family history of sudden cardiac death, identify these individuals, do a genetic polling, and find out who are the high risk individuals based on a score. Another important thing is all of these usual tests that we do in a regular hospital would again cost around 5,000 rupees. And this test, for a 5,000 rupees one-time payment, you're able to identify high-risk individuals, and that's how you can pick them up for more aggressive treatment. The last point that I wish to say is that apart from being a once-in-a-lifetime study, the importance of this is for such individuals, you can come up with new cutoff scores. Now we have LDL values for those wherein we advise intensive lifestyle modification. So if such individuals who have a higher genetic score are picked up, maybe we can come up with newer cutoff values so that these individuals can have a more aggressive lifestyle modification measures that are instituted in them, and we can reduce their risk. So we go up with more aggressive measures for them, more frequent follow-ups, and ask them to report to the hospital much earlier in the event of symptoms, and also alert the family that such individuals are more likely to face a coronary event. So with such measures, I think this study is a very refreshing perspective on coronary artery disease, much required in our scenario where coronary artery disease is very rampant, very severe, and catches people young. So as rightly pointed out, if we can identify individuals at the age of 15 and pick them up for more intensive cutoff values as well as lifestyle modification, I think the objective is served.
Okay, Dr. Bagheera, thank you very much for those kind words. Over to Dr. Pradeep, if you could quickly give us our inputs, and we'll have a Q&A after Dr. Pradeep.
Sure.
So,
thank you. I won't be long. I
you
think
can request.
most things have already been discussed. I just want to highlight a couple of things which I, reading the paper, found quite interesting and has not been touched upon so far. Firstly, that this polygenic score independently predicts the risk. So even if you're a diabetic or a hypertensive or you're obese or a smoker, so irrespective of even after adjusting for these things, this score tells us independently what our risk factor is. I think that's quite important. Secondly, earlier on, we were talking about screening. For any tool to be effective as a screening tool, it has to have a high prevalence. And I was reading about it that this polygenic score has a 10-fold higher prevalence among patients who present with early onset MI. So I think this is absolutely phenomenal. We have taken a giant leap in the future here. And if I may add just one last point, that again, according to this paper, 5% of the Indian population have triple the normal risk. Now, if you think of the population we have, this is very scary. But at the same time, I think it's also very reassuring that we can identify these people, and we can, at the moment, we can just maybe introduce lifestyle modifications, but I'm sure in future, the time will come when we'll be able to attenuate these scores and prevent these people from becoming patients. Thank you very much.
Okay, thank you very much, Dr. Pradeep. We'll go ahead with the Q&A. So the floor is open. So journalists, please do raise your hands and I will unmute you. And alternately, we've got some questions in the chat window also, so we'll address them. So yeah, so we can go ahead. So I think I'll just read off a couple of questions from the chat window. So how many organizations collaborated for the study, and where was the research conducted? What is the incidence of CAD currently in India versus global? And cost of the test has already been discussed. And what can be expected from this technology?
Yeah, so maybe I'll take this up. So there were 6 organizations, so 6 large hospital centers. As I mentioned, to start with, we initiated with Madras Medical Mission, Eternal Heart Center from Jaipur, Narayan Hridayalaya played a significant role because we are pretty close to them here in the same campus, and Amrita Institute from Kochi, KMCH from Coimbatore. These are the centers that participate in this study, and each one contributed to their clinical cases with complete clinical profile of the individuals or the patients, and we collected about 2 ml of blood sample with the consents, and IRB is approved. Then the whole work was done at MedGenome in Bangalore, and there was a good amount of technical help that we got from Harvard Institute, Broad Institute, or Harvard University through Sheikh's lab, Dr. Sheikh Kathresan's lab there, and because since they have been pretty much experienced in that, so we basically got the fundamental or the starting statistical model from them, which was made for a Caucasian population. While it is similar to the same what we are using currently, but significant changes have been done to incorporate what we call it as specific gene panel or imputation panel needed for our ethnicity. There is a South Asian ethnicity, which will improve the scores, accuracy, and also the right way of doing things. So apart from the clinical centers, we collaborated with Broad Institute in US. Unfortunately, we couldn't have Sheikh on this one. And this second one, we told about the cost, and I think that's it, Joseph.
Yes. So the next question is, which are the diseases that will benefit from this, and any takeaway for the general public?
Yeah. So, so in general, if you look at you review the literature, almost all common diseases, which includes coronary artery disease, hypertension, diabetes, breast cancer, inflammatory bowel disease, schizophrenia. There are so many other diseases which are there, for which there are what we call in technical terms heritability well established, which means there is a genetic basis which have been proven. People are implementing polygenic risk scores. In US, there are several companies and health centers who have already implemented diabetes, who have implemented breast cancer polygenic risk score, very for large number of individuals who are getting tested for this. So this can be done, but what needs very, very critically is the validation of the whole process of the test. The calculation of the risk scores are very important, because there is quite a bit of variability as to how you do it. So proof in the pudding is extremely critical. So that's the reason why we waited for the study to be published, have a peer review. The scores have to be, if not as accurate as a diagnostic test, but at least reliable, with a clear sensitivity and specificity defined, what one can expect on that, and what are the parameters before we go ahead. So there are several organizations, as far as we know, at least published, in India, there is no one who is doing currently this one. We have started for coronary artery disease because this is one of the most impactful disease that we can do, especially in the young patients. We have started on diabetes. We hope to finish that in the next 2 months. And we will be starting on hypertension also. If everything goes through, the cost of about 5 to 6,000 rupees, we can do the polygenic risk score for 3 diseases at one time. Again, I wanted to alert everybody, this is not like a pure genetic disease. It's a screening one, gives you a nice idea. We have picked up, in fact, blindly, we have picked up 2 to 3 individuals who are having coronary artery disease. And at the age of 36, 37, we picked up the cases as a blinded study. So it works pretty well as far as the precision is concerned and positive predictive value is concerned. But having said that, if polygenic risk score is low, doesn't mean that individual doesn't get a coronary artery disease. There are various ways it can come. At the same time, there could be some individuals who can be branded as high risk, but they may not be really in a high risk. So again, there could be about 7 to 10% of cases like that. So we need to balance it out, but pretty much this gives you a good handle especially for the individuals who are in a high risk environment or high risk family history, everything is there. And also for clinicians, if they wanted to stratify. I really appreciate one point told by, I think, Dr. Pradeep, stressing, I think, Dr. Rajiv, that somebody has already a heart attack and he underwent treatment. They want to know where the second time is going to come. In fact, there was one nice study published already showing that polygenic risk scores will really predict the second heart attack for individuals who already had MI already. So there are various applications that we can do with this.
Okay, so we have a hand raised from Mr. Gyanaprakasam. So please go ahead with your question. I'll unmute you now.
So now the science has become so advanced. You are talking about genetic transmission. Is there possibility to break the genetic transmission, sir? Can you hear me?
Yeah, I can hear.
Yeah. You got the question, sir?
Yes. So, but you mean to say whether those genes or risk variants can be stopped from inherited, right?
Yes. Just been, we have been talking this genetic for so long, so many decades something there. The science has become so advanced. Is there any possibilities that to break the genetic,
No, so you can't stop genes, inheriting genes, good or bad, from your parents, right? So we all get one copy of our genes from our father and one copy from our mother, right? So so you can't change that. Nobody can change at this point of time. But what is happening, again, it's a pity that Dr. Sheikh is not there. He's doing something remarkable. With Therapeutics, he's editing bad genes. So basically, there are various ways how you can edit genes which have not been so far clinically gone through clinical trials or approved, but there is a good proof, at least in early stages, where in some of the diseases, if not in all of them, some different methodologies have been used to how to change the bad variant or a mutation. And they have shown, in fact, recent studies published by Dr. Shekhar Kadresan's group have shown in monkeys, they have edited, they call it as a base editing, a single gene variant is edited, and they have shown monkeys it works pretty well. So it's something that we expect it will happen in a few years to come, sir.
Okay. Thank you very much, sir.
Thank you.
We have a couple of more questions in the chat window. So what is the scenario globally? Are under 40 years olds manifesting with CAD? Where is the test made available in India? What age group was roped in for the study? How many women participants were included in the participants?
First point, I think I'm not a real expert. I leave it to clinicians here, especially Dr. Ajit and Dr. Julius. So the second part of the question, sorry, anyone here? Okay. The second part, we can, the whole thing can be processed at our lab, and I'm pretty sure there are a few other centers who have the capabilities to do it in India currently. As far as women participants, whenever we design the study, we ensure that there is a gender matching happens. That means how many of our male participants we take in most of the studies, we need to ensure that equal number of women also involved, so that there's no bias in that. So we have done accordingly. So the first part of it, the question, what is it, Joseph?
What is the global scenario? What is the global scenario in terms of manifestation of CAD? Is it under 40?
I'll leave it to Dr. Ajit Mulaseri if he's there. You can unmute it.
Dr. Ajit, I've just unmuted you. You can go ahead, sir.
Can you hear me?
Yes, Dr. Ajit, you can go ahead.
So young MI is very common in India. It's about 22% in our paper in JAMA. We think that it's very important to risk stratify these patients because they have the highest polygenic risk score, like Ram Prasad said, and they may have an odds ratio of close to 3.5 or 4, which means very 4 times higher risk than normal people. And they will have to be aggressively treated with high-dose statins and maybe the newer drugs like PCSK9 and other base. Right now, we can only say that the most important thing is to see that we can predict the highest risk group and tell them you need to be very careful with yourself. You may be lean, you may be a very athletic person, you may be having very low cholesterols on traditional numbers, but your numbers will have to be very low. Otherwise, what will happen is that you will get coronary artery disease very early anyway. So I think the most important step here in this polygenic risk scoring now is to validate this in a larger sample in multiple places in the country, number one. Get the highest group of people with the highest risk, which may include young MI patients and patients with family history, and then treat them aggressively with what we can right now. Thank you.
Yes, so yeah, thank you very much, Dr. Ajit, for that. So a couple of questions in the chat again. So what is the age at which a layman can take this test? I think we've already answered that.
So technically, this test can be done at any age, but you have to look into clinical situations and various other psychological issues and other things. Usually when we do genetic tests, unless until it's needed, we don't do for minors. We do it only for adult individuals, such cases, unless and until the individual is affected and very bad, we do it. So technically we can do when the baby is born to any age. as long as you get the DNA.
Okay, the floor is now open. Anybody has any more questions, please unmute yourself and ask the questions. Or if you are not able to unmute, please raise your hands. I'll unmute you. Dr. Rajiv Gupta, your hand is raised, sir. I'll just unmute you. Yes, sir. You can go ahead, Dr. Rajiv Gupta.
Yeah. So two issues have come up in the last 1 hour or so. One is the question about burden of disease. So we have done some work on that. We have used two databases. One is the Government of India database, another is the Global Burden of Disease. Now, thing to note here is in terms of disease burden, that means the disability adjusted life years, which takes into account prematurity of the disease. India is #1 country in the world. We are even bigger than China in terms of disease burden. In terms of the mortality from heart disease, again, India is on #1 position. Unfortunately, in India, the disease burden is increasing in the last 20 years, while it is declining also in China, especially also in the developed countries. So I think we have a double-edged sword on our head that we are young, so we get the disease at a younger age, and the burden is increasing in the last 20 years as compared to the developed countries. The second question was about the real burden of premature heart disease. Now, premature heart disease is defined as men less than 55 and women less than 60. And that's what the sample size was there in this particular study. So clearly, both men and women are involved in creation of this particular gene risk score. Number three is the how many people of the premature people get heart attacks. Now, Dr. Ajit just said that almost 40% people are premature, and in our database, also in our hospital, which is one of the largest centers in the state of Rajasthan. Again, about 40% of close to 50% people are premature. So clearly, it's a huge burden in terms of the disease burden in our country. And finally, I think one question is very important to realize is that all the gene tests are done after a proper consenting procedure. We can't do gene tests left and right. A person who's getting the test has to be aware of the results. And that is a major area of further research, that if you tell a person that he is at a high risk, what happens to him? Does he get depressed? Does he get nervous? Does he get anxious? So all these things are to be answered before we apply this particular gene test into clinical practice. Thank you.
Dr. Pradeep, you had your hand raised, so I have just unmuted you. You can go ahead.
Yeah, thank you. I think I may have misunderstood the question, but I think the question was, what was the incidence of heart disease in people less than 40 years old in the Western world? And I think that's a very uncommon phenomena. I think the average age for people getting heart disease in the West is around 60. So this is something very unique to our country. And that is why I think this test is extremely relevant to our country. That's just the point I wanted to highlight. Thank you.
Thank you very much. Any more questions? If not, we'll wind up for today. Dr. Muralidhar had a couple of comments. Yes, I'll just unmute you. Yeah, Dr. Muralidhar, please go ahead.
Thank you very much for this opportunity. Can you hear me?
Yes, sir, we can hear you. Please go ahead.
It is, if you look at the National Commission on Microeconomics published by Indian government, it is clear that even in people who are between 20 to 30 years of age, the incidence of coronary artery disease is going up. So if you get a patient between 20 to 30 years with chest pain to the casualty, we need to look at them more carefully because they may be suffering from coronary artery disease. And its usual tendency is to tell that you're only 25, there will be nothing wrong with your heart. That's not true at all. So this segment is growing if you look at the National Commission report. And also I would like to add that it is absolutely exciting to see that integration of many DNA variants to a single number is able to predict the occurrence of coronary artery disease. Very nice, nicely demonstrated. Congratulations to MedGenome Group. And we also know that South Asians contribute about 23% of world population. And as someone else said, the South Asians or Asian population is 3 times more vulnerable to coronary artery disease. So the magnitude of the problem is huge, and this genomic polygenic scoring system is would be highly useful in preventing the occurrence of serious forms of heart illness as the age progresses. And I liked what Bhagirath said about the new cutoff values for those people who are vulnerable. That's a very important point. I think if you know that a person is susceptible or vulnerable to coronary artery disease, we might have to look at the values which we get from the laboratory more closely and control them more tightly to be able to prevent catastrophic events in the particular individuals. These are my comments, and thank you very much for involving us in this huge study, and we are really indebted to the MedGenome.
Thank you very much, Dr. Muralidhar.
Thank you.
So we have one more question. Mr. Unnikrishnan asks, what is the percentage of variability in the risk scores?
Yeah, so it's I don't know how deep I can go onto this. So whenever we do it, come up with a test, we will do what is called analytical validation, which comes up with certain parameters like sensitivity, specificity, NPV values, PPV values, and odds ratios, relative risk, like that. And it depends upon how we do also. The study design is also important. So currently, when we did the case control with about 1,800 cases and 1,600 or odd controls totally, we have a sensitivity of about 50 to 60%, which means that we still don't pick about 30 to 40% of the cases. But the predictive value, that means the positive predictive value, which means the specificity, which means when I tag an individual, he's high risk, he needs to be a high risk, is about 90% currently. Now, this is based on some of the stringent filters that we use or parameters we use, okay? So there can be some changes that we can do in parameters to either increase the sensitivity or specificity depending upon the situation. Usually screening tests nobody anticipates screening tests to be 100% sensitive or 100% specific. These are usually used to identify quickly. It's like doing rapid antigen test in COVID. Okay, they are not, they miss a lot of cases, but at least you can pick the positive cases. So currently it is, our PP is 90%, our sensitivity is around 50%. And odds ratio on these individuals is about 3.4 for individuals who get high polygenic risk score. And it's pretty significant at this point of time.
Okay, so I think we are more or less done. If there are any more questions, I don't think so. Okay, so I think we'll conclude the program here. So on behalf of MedGenome, I wanted to thank the audience for taking time off from their busy schedule and attending this press conference. Especially, we should thank the eminent doctors on our panel who are under extreme, they have an extremely busy schedule, and even then they're taking time off and giving their valuable inputs. And to our friends in the journalistic community, if you have any additional questions, please don't hesitate to reach out to us through our website or through our toll-free number or to our PR agency. So we'll be glad to clarify any additional questions that you might have about polygenic risk score and any other aspects. Yeah, so thank you very much, everyone, for taking time off and coming for this press conference. I hope you've got a very good insight on polygenic risk score and its future potential in India. So thank you once again, and have a nice day and stay safe.